Okay, this is our third video for our GI tract. Our anti-secretory agent that enhances mucosal defenses. This one, we don't have that many medications for this. Misoprostol or Cytotec, this protects against NSAID-induced ulcers by stimulating secretion of mucus and bicarb. And we know mucus and bicarb are some of our defenses against or to maintain the physiology, the normal physiology of the gut. And it maintains submucosal blood flow. Submucosal, all that means it's under what? It's in the cellular lining. That's where it needs to be. And suppressing secretion of gastric acid. So it's a fairly decent drug. It is a prostaglandin defensive factor to protect physiologically from self-digestion. That's what we would refer to it. And interestingly enough, this is also used vaginally. This prostaglandin is used to terminate a pregnancy by starting labor. So again, when we ask you, why is your patient taking it, you have to know why you're giving it and why this patient is taking this medication. So you can kind of see their very different reasons, either to terminate a pregnancy or actually to start labor, or that it's going to maintain our submucosal blood flow by stimulating secretion of mucus and bicarb. And then we have to talk about our antacids. We know what that is. It reacts with gastric acid to form neutral salts. It's going to neutralize that acid. And these are the three most common: aluminum hydroxide, calcium carbonate, and magnesium, which you can all buy, all of these in the store, over the counter. Laxatives. We can't leave the GI tract without talking about laxatives. We know indications for laxative use is going to be constipation. And constipation is determined by stool frequency and consistency. You know, how often are you? You may have decent stools, but you may go once a week. So, you know, it just depends. It's contraindicated. Laxatives are always contraindicated for people with abdominal pain. We need to find out, is it constipation or something else going on? Nausea, cramps, and that could be any abdominal cramp. It doesn't necessarily mean, you know, a woman with the menstrual cramps. We're talking about abdominal cramps. Symptoms of appendicitis, diverticulitis. If ever there's a fever, we think there might be an inflammatory process. It may not be constipation. And then, of course, ulcerative colitis, which we've talked about. It's used to ease or stimulate defecation, like soften the stool, increase stool volume, hasten stool passage through the intestine, or facilitate passage of stool from the rectum. There's lots of abuse issues, especially with the elderly, because nobody wants to talk about this. If you want a project for a master's thesis, you know, go somewhere, a nursing home, and talk about laxatives, because people don't want to talk about it, which is so crazy, because it's just like eating. We all have to do it. But the most important thing to remember is, and you need to write it somewhere, is that not everybody has to have a bowel movement every day. People have different patterns. Some people it's every other day. Some people it's every third day. And that's about it. If you're going 4, 5, or 6 days, there might be an issue where you really need maybe a bulk laxative. You need a lot more fiber in your diet. And some people have a ton of fiber in their diet, and they still need a bulk laxative. And there can be a hereditary component. So we have to educate on the topic of laxatives. Establish consistent time of day to have a bowel movement, just kind of like, you know, how we all get up and have coffee. You know, we have lunch at a certain time, not all the time, but most of the time. They say that with insomnia, you know, go to bed every night at the same time. That helps the body establish a biological clock. So same thing with passing a stool. If you can establish a consistent time to have a bowel movement, and I know a lot of us can't talk to our colon, I get it, but you know what I'm getting at. It's a good thing that if it's going to be better for them in the morning, they know when they're home, or maybe there's be better for them to have that at night. Exercise. Here I go on my mantra, especially after meals. What does that do? Of course, if you ate like a Thanksgiving dinner and you're laying on the floor like I do because of so many carbs, you know, that's a different story. But you know what I'm saying. If you're eating decently, exercise. And if you're really too full, wait an hour, but then exercise. All that does is just even getting up facilitates gravity to be pulling that food down to where it needs to go. Increase fiber always. bran, fruits, vegetables, and increase water. How can I say it? You always see me with the water bottle, you guys. Everybody, you ought to be drinking half of your weight. If you weigh 120 pounds, you need to be drinking 60 ounces of water. If you weigh 150 pounds, you need to be drinking 75 ounces of water. And everybody needs that, not just us, everybody. Now, if you have an elderly person and they're in congestive heart failure or heart failure, you're going to revisit that thought a little bit because the extra fluid may hurt them. But I'm talking about normal people with constipation. Okay. Classification of laxatives. We have our bulk forming laxatives, which is temporary constipation. That would be like Metamucil or Psyllium, whatever you want to call it. It's such a great, it's actually, Metamucil you can take all day long. Even though it's called a bulk laxative, if you look at what is in it, all it is fiber. So if you know anybody that has a problem with this, you take 2 teaspoons of this Metamucil. They have orange flavored now. I'm always buying it for people in my family. We all have a tendency for this. And they have orange flavored, and they just came out with one that's low sugar. So, if you're watching carbs or if you're counting calories, it's not even 2 tablespoons. It's 2 teaspoons. It's like 45 calories. And it'll be the best stool you ever see. I'm not kidding. I know I sound like I'm advertising for them. But anyway, that's the best bulk forming laxative because it basically bulks the stool out and slides it out of the colon. And it's not really, me and chemicals, I don't like them. There aren't any chemicals. It's just fiber. You can have it 4, 5, 6 times a day. It's not going to hurt you. But it needs to be taken with lots of water. Bulk laxative will decrease diarrhea in clients with diverticulosis because it bulks it up. So it's actually a good thing, even though it's called a laxative. It will decrease diarrhea in people with diverticulosis or irritable bowel syndrome. It also controls diarrhea for clients with an ileostomy or a colostomy. It promotes defecation in older adults with a decrease in peristalsis to age-related changes in the GI tract. So it's just a really, it's a good entity. You can get it anywhere, Walmart, anywhere. Okay, surfactant laxatives. What's that? That's our sodium. I can never say that word, but Colace. Colace is another one. Never used to be able to, but now you can buy it over the counter. It's often given postoperatively. It's used in patients for short-term use, pregnancy, or opioid use. Used for patients to prevent painful elimination. So if somebody who has an episiotomy is having a baby or hemorrhoids, like have a hemorrhoidectomy, it's to help them to prevent from straining because they have some type of hernia repair. Anything that's lower abdominal incision where you have to, kind of bear down. Well, Colace will help you not. It softens the stool. Stool softener, surfactant laxative. That's what that does. Anybody who's had like an aneurysm or post-MI, myocardial infarction, they don't want them to strain either. Or the elderly who has diminished peristalsis. That's for Colace. Cramping for stimulant laxatives are Dulcolax or Bisacodyl. Cramping is very common. Only be given with good bowel action. Make sure there is peristalsis. And they're the laxatives people hate because severe cramping, it's basically pushing it through, as it says, stimulant. And most of those are taken with Senna, which is a herbal product given with laxatives. Okay. Bulk forming laxatives, to go back to our Metamucil, they're non-digestible and non-absorbable. They swell in water to form a viscous solution or gel, thereby softening the fecal mass and increasing its bulk. That's why it's called bulk laxative. So you have to take that with a lot of water. And when you're mixing it, I only mix it with 8 to 10 ounces of water. But you have to drink it fast because it gets very, very thick. So if it does thicken on you, it just looks like this goobity glock that you could, talk about Halloween coming. You could turn it green and really, it would look like real bad stuff. But anyway, just add water. All you have to do is add water, stir it, and drink it. Okay, I think that's enough about laxatives. Okay, let's talk about our antiemetics. And these are medications to keep us from vomiting, suppress nausea and vomiting. The emetic response is brought about by the activation of the vomiting center in the brain. It's a nucleus of neurons located in the medulla oblongata. Some stimuli activate the vomiting center directly, some indirectly. Indirect acting stimuli first activate what we call the CTZ, or the chemoreceptor trigger zone, which in turn activates the vomiting center. Activation of that vomiting center occurs in two ways: by signals from the stomach and small intestine traveling along the vagal afferents, by the direct action of our emetogenic compounds, such as anti-cancer drugs, opioids, anything else that we're putting into the body, not just something coming from the stomach or the intestine. And obviously, it would have to come from there because that's where the vomit comes out of. So again, don't have to memorize. It makes sense. But then the direct action of our emetogenic compounds, all that means, because emetogenic, it's going to produce vomit. Once activated, the vomiting center triggers the stomach and the diaphragm. We know, anybody that's ever vomited, you're trying so hard not to, and it's just an ejection response of your abdomen via the diaphragm and abdominal muscles, and result in expelled gastric contents. Again, the CTZ is called the chemoreceptor trigger zone. For management of chemo-induced, we call it chemo-induced nausea and vomiting, antiemetics are more effective when given before chemotherapy. So usually before they ever even give the chemotherapy, because of this center that they know is going to be activated, they actually give Zofran usually before they give the chemotherapeutics, just to try to control it. Serotonin antagonists are a group of the antiemetics. Zofran is one of the best ones used now. Years ago we didn't have it, but it's been around for a while now. It blocks 3 serotonin receptors on that afferent vagal nerve. And then Anzimet's another one. Zofran, they say it's a very, very expensive drug, about $90 a pill. Can you believe that? Used prior to cancer treatments to prevent emesis. These are the most effective drugs to suppress nausea and vomiting associated with radiation and anesthesia. Zofran is a very popular, commonly used drug. Okay, then we're going to move on to our glucocorticoids. For the gut, Solumedrol, very common used in the hospital IV. So is Decadron. Both of these are commonly used to suppress, and there it is, chemo-induced nausea and vomiting, and there's an abbreviation of CINV. Are effective alone or in combination with other antiemetics. Sometimes you'll see Solumedrol with Zofran if somebody's really losing it with nausea. Are effective alone and in combination with other antiemetics. Mechanism is unknown. They don't know why the Solumedrol and the Decadron, their anti-inflammatory processes we know are huge, but they've not been able to connect nausea and vomiting to inflammation. But I don't think it's that property. I think it's the property of, with especially the methylprednisolone. Well, Decadron is prednisone, also glucocorticoid, not a prednisone, glucocorticoid. Is that it promotes an overall sense of well-being. That's all over the literature with these drugs, glucocorticoids. So I think that's why it works well. Okay, I'm going to have to stop here or the recording is not going to go. So we will actually have a third, this is the third one. We'll have a fourth video for the meds for GI.